Now, what is going to happen and how we are going to run these sessions is that I am not blocking the ability for you to unmute yourself. So you are able to unmute and you can ask the question. If you would like to introduce yourself and ask the question, that would be great. And then answer it. And then when you, if any one of you would like to add anything to the questions or to the answers, please feel free as well to unmute, and I will be happy to also contribute. So any contribution here today is welcome. As many questions as you would like to do. For those who don't know me, I am a consultant pathologist here in the United Kingdom. I work in Essex. So for those who already know me, so that you know this piece of information. I like to train people for the exam, our fellows, our registrars, and our specialists for sitting the exam. So I have some insights into this. So this is why I'm conducting this session. So enough of this long introduction now, so we can start the session. And as I said, anyone would like to ask the question, please unmute yourself and ask the question. And then I will we will all hear it, of course, and then I can answer the questions. So, but don't forget to unmute yourself, because otherwise we won't hear you. So please start. Any one of you who would like to unmute and start, please. Thank you.
Hello, Dr. Ahmed.
Hi.
Hi. I want to ask about OSPI 1 and OSPI 2, and how could we prepare for this item specifically in FRCPath Part 2 exam?
Okay. So there is an OSPI 1 and OSPI 2. One of them, we call it the written OSPI. And this written OSPI is basically targeting some routine or normal, very easy pathological description of something. So this is the first part of that part of the exam. So they probably will put, for example, pictures of a malignant melanoma that no one will argue that this is a definite malignant melanoma. And then they will ask you to say, how do you diagnose it? What is the main prognostic features behind this type of neoplasm? And then the third and the fourth questions will be targeting the molecular aspect of these questions. So what at the college try to do for the written OSPI is to target your molecular knowledge. But it has to be a molecular knowledge for a common scenarios. So these common scenarios can be either something to do with the breast molecular, like the BRCA1, BRCA2. It can probably do with the HER2 testing. So what they might ask, what do you think of the HER2 testing? Why do we do it? What is the significance of the HER2 to be positive or negative? How that may reflect on the patient's treatment and on the prognostication. And then they tend to ask you as well about the technique of doing the test. So if, for example, you are going to test by immunohistochemistry and FISH for HER2, then they might ask you what are the different methods that you might come across to test for HER2. And then you say immunohistochemistry, and they then ask you in the following questions, what are the advantages and disadvantages of either? So then you need to be able to say why HER2 immunohistochemistry is good and what's bad for it. And then what you need to do is to go for the FISH analysis and say why it is good or why it is bad. So, for example, in a breast, but in other cases in melanoma, most of the questions after you say the diagnosis and the prognostication, like the data set item, like lymphovascular invasion, depth of invasion, number of mitosis, presence of ulceration, all of these are prognostic factors. Providing that you listed them and you state next to them, is it good or bad, of course. But then what you will be answering a lot of questions about BRAF. How do we test for BRAF? You can test for it, of course, by there are some immunohistochemistry now in some part of the world that you can test for BRAF with, but you can also do the rapid gene sequencing or PCR or whatever. But what they will then ask you about which one is the favorite test or method of testing for BRAF V600, and what is the significance of this, what type of treatment this might dictate, and all of those sort of things. So the OSPI part 1 will be targeting these common ones that comes every day. I remember on my exam, they probably asked me more about the dysplastic nevi syndrome and how they put a dysplastic nevus pictures in the exam, and then they asked about what is the diagnosis, why would you and you have to say why it's not melanoma, of course, and then they ask you about that syndrome. However, the question about the syndrome itself, do you know of any familiar syndrome that might harbor this kind of diagnosis? And then this is what it was. But usually, because the mark is broken between your microscopic description, your diagnosis of the condition, your prognostic values. Of course, the prognostic values is easy because you can make it up. Even if I ask you why immunohistochemistry is a good test, you can make it up even if you don't have the knowledge for it, because you can tell me, oh, it is cheap, it is available in most of the lab. Interpretation for the results is possible for all the pathologists. However, as you know, the pitfall for it that you have false negative, you have false positive. It depends on technical abilities. It needs verifications every few months that you make sure the antibody is working. And you have, of course, the cross-reactivity with other conditions, which can give you all sort of results. So what I mean is that you can make it up, providing that you make it systematic. And these are not like making up, like giving a false information. You are giving the information that you have learned about this over 2 or 3 years of your training in pathology, if you are a junior doctor. But if you have worked for 10 years or 15 years, I'm sure you know all these sort of things. But the good things to train for it is to go general. Like, you need to know what is the real advantage of a FISH test for anything. What is the pros and cons for a FISH test? What is the pros and cons for a real PCR test? What is the good things about the rapid gene sequencing? And if you know those, these are the majority of the methods that's used nowadays in England. If we want to do molecular testing, we will either ask for FISH, we ask for PCR, or we will ask for rapid gene sequencing. So providing that you know what's for and what's against each one of those in general talk, then you can fit it in. See, so that will be like the dress that you can fit for any type of scenarios, because that will be the stamped format. It is like when you are preparing for a micro questions for granulomatous inflammation, either you get this granulomatous inflammation in the lung, even if you get it in the testicles, you get it in a lymph node, you probably will answer in the same way. It is the same framework. And you still have to do the special stains. You still have to do the skin test, all of these sort of things that comes around that will make you score more points. So it is the same things for this OSPI-1. The only problem of the OSPI-1, I think that it comes to the time when you are exhausted during the exam, and sometimes you just want to leave, and you are thinking about all the mistakes that you have done in the hour before, or what happened in the frozen sections, or what happened in the day before. So sometimes it creates a lot of, your brain is a little bit cloudy. But providing that you have this format, it is like the cards that you just use it for all trades. You see the card for all trades. So this is what it is. That's providing that you know what you will write about IHC, what you will write about FISH, what you can write about real-time PCR, what you can write about rapid gene sequencing, then it is the same pros and cons for any molecular test. So, but because the mark is quite divided, so you probably will pass the minute that you talk about the microscopic description and the diagnosis, because you will be required to give those two in the first part of the question. So you probably have passed already the station, but and then whatever you write in the molecular testing, even if it does score you 2 or 3 marks, then you will pass. So you will be fine. So it is very hard. The only time that you will fail, if I am giving you, for example, a cytology, and then I give you a cytology specimen, and then I ask you what is the diagnosis from a lung, for example, from a pleural aspirate, and it is bang adenocarcinoma, with all the papillary architectures and everything, and then you tell me it is benign. Well, this is just break the point. The point is that it wasn't about the cleverness of the diagnosis. Anyone would have seen the picture, will know that this is adenocarcinoma. By the way, they don't give you a slide. They will give you the picture, one still image of the slide, and it's adenocarcinoma. It's like a textbook picture. And or if it is a melanoma, it will be a picture. If it is an adenocarcinoma, breast lobular carcinoma or something, it would be a picture. So if I give you a picture of a lobular carcinoma and you tell me that all what you see is a fibroblastic proliferation and you call it something else, then you break the point here that you don't know what lobular carcinoma really looks like, then you shouldn't be sitting the FRCPath exam. And it will be like the greatest ever adenocarcinoma that you have seen in your life. If I give you a picture of adenocarcinoma in a colorectal tumor, and you don't know that this is adenocarcinoma, then you shouldn't set the FRCPath exam, because the picture will be like a textbook picture for adenocarcinoma that even anyone who never saw pathology before and the medical students year 1 will know that this is adenocarcinoma. So don't worry, don't panic, the picture will be easy, and don't try to complicate it for yourself. If you think it's adenocarcinoma, then it's adenocarcinoma, and all what they need to know now is that you tell them what is the common, for example, if it's a lung adenocarcinoma, what are the common molecular testing that we do, like PD-L1, like ALK1, EGFR, and then how do we test for those? What is the value of testing for those, and how that will affect the patient treatment pathway? So all of those are things which we might put. If we put a colorectal cancer, then we will be asking you about the mismatch repair genes. What are they, and how you interpret them? So you should know what is MLH1, what's MLH6, you should know that combination of the 4. And you should know what is the commonest format of them, and how do we test for them, and what is the value for having this, because it can affect it of course it runs in families, and it can be recurring in another as a synchronous tumor, and all of those sort of things. So this is for the OSPI part 1. for the written OSPI, the OSPI, which is the management OSPI, it is when you get called. So you get called and you sit in front of the examination room for about 2 or 3 minutes. They give you a card with some scenario written. Now, because some of you might be very stressed, and usually the scenario is about 5 or 6 lines, and some of you might get very stressed about it and they don't see it clearly or they don't recall the information. What I will recommend that when you sit with a card, you have to have an empty piece of paper with you and a pen, and just write what is your point that you got from that scenario, because you might not be able to recall. So just write quickly what is you think of that scenario, what is the conflict is, who's involved with this conflict, and what is the main obstacles of this conflict that you need to issue. The scenarios will be something to do with the problems that happens in the departments from day to day, something that between misdiagnosis, or an argument between colleagues about a certain diagnosis. So things that you see every day in every department, or it might be related to sample mismatch, like you are talking about the benign radiology, everything is benign, and you're getting a malignant, bang on malignant core, and you take it to the MDT, they say, the radiologist telling you this is a definite 100% fibroadenoma. How you will resolve something like this, and you have to go back and see if there was another case with discrepancy. You go through the list of the cases has been seen on this day, and you try to, you go back to the slides, make sure that the slide was labeled correct, labeled with the right histology numbers, all of those sort of things. So what I mean, the management, it's all about being systematic. Of course, I cannot tell you every single scenario today because this is not dedicated for this. But what I can tell you, it's about being systematic, that you sit in front of the examiner. If you didn't finish the reading and they called you inside the room where the 2 examiners sitting, just tell them, please give me 2 more minutes till I finalize reading the scenario. So don't be shy. If you haven't read it because you are a slow reader or you got a mental block while you were reading it outside the examination room, just when you go in, give yourself a chance and read it. And then after you finish reading, say, yeah, thank you very much, I am ready now. And then they will tell you, okay, you understand the scenario? Yes, I understand the scenario very well. The scenario has got 3 main issues here: issue 1, issue 2, issue 3. The people who are involved in this are personality or person number A, B, and C, okay? The conflict or the main concerns regarding the patient safety in this is that, right? And then you can target it. There will be a lot of buzzwords that you have, because you will have to come in this management scenario. You give the introduction about understanding the conflict, understanding the sincerity of it, how serious something like that can be. And then the second things that will be examined and tested in the management scenario is your understanding of how labs work, right? Because you are not detached from the real world, so you know the sequence of a specimen, where the mistakes might happen. It might happen before we receive, or while we receive it, or while we process it, or maybe after we do, like putting it in the wrong report, which happened to all of us sometimes. And then the other things that you need to address as well is the hierarchical system, that you know what is the chain of commands in England, that you have, of course, the clinical team, the clinical lead, the departmental lead, the clinical director and the medical directors, and then you go to the board and the chief executive. So providing that you follow this path, then you are absolutely fine. providing that, for example, you know what is occupational health mean. So there are some buzzwords like audit, like learning from mistake, do reflection, protecting but not harming. So you have to protect the emotions of your colleagues. You have to show respect, but you have to preserve the patient safety. So these are the buzzwords that you need to mention them. So whenever you answer any questions, you always have to say the good relationship between colleagues, the probity and maintaining good medical practice, and maintaining the confidentiality. All of these buzzwords that comes with the general, with the GMC, good medical practice, there are 9 pillars for good medical practice. If you go to the GMC and write the word good medical practice, you will find like 9 things that the good doctors has to maintain. And these are the 9 things that you need to bring some of them in your answer. And then you will find the time flying, providing that you give them a chance to ask questions. You see, don't keep talking and bluffing. What I would like you to say, the conflict is the people involved are, and the problem here include this and this and this. For problem number 1, this is what needs to happen, blah, 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 2 short sentences. For problem number 2, this is what needs to happen. For problem number 3, this is what needs to happen, okay? So now, you give them now, after the first 3 or 4 minutes, a chance to ask you questions, but every time they ask you questions, you have to say, try to give yourself a time to think and just tell them, very interesting questions. Let me just think for a few seconds about it and rearrange your thinking again. Don't be like a bullet just coming up with an answer. That doesn't leave a good impression. Always take a step back, think what do they mean by this question, so you don't give the wrong answer, right? So they might tell you, should we strike this colleague from work because he's done too many mistakes now? Okay, this is, you just have to breathe and say, this is not a decision for me to make. These decisions comes from the higher authorities, and this has to be thoroughly investigated before decisions like such as this is done. We don't decide for other people what to do, okay? We don't go with a big heart and try to do things by ourselves. Everything has to follow a hierarchical system, and investigation has to be conducted. And then based on the investigations and the detailed analysis, then you come back with an answer. Also, you have to be familiar with something that we call it DATICS, which is like incident reporting in any hospital. So these are also a common word that you have to use it in the management scenarios, that if there is an incident, you have to report it. And this based on how serious it becomes, like a major, or if it involves patient harm, or it is near miss, if it didn't have patient harm but could have caused, or a minor incident. So providing that you know all these categories and you mention them in your answer, then you should be fine. But the key really is that you will have about 10 to 12 minutes to talk inside that station, and you have to give them time to ask questions. If you think that you start talking too much, then stop talking and say it. I'm sorry I talk too much, but let me summarize what I have said. Number 1, number 2, number 3, right? So always go back to the basics and try to be more organized when you answer. If you are one of those who love talking like myself, when I start talking, nobody can stop me, then in this station, just remember you only have 12 or 13 minutes, and they need to ask you the 5 questions so they can score you. If all what happened that they ask you 1 question, then blame yourself after you come out. Don't think, oh, I kept talking and they didn't ask me any question. They didn't ask you any questions. That's your mistake, Okay, so I hope that this has answered you. Any more comments about these two questions? You can unmute yourself for those who just joined and tell us. You can unmute. I'm allowing everyone to unmute herself.
I have a question to ask in this regard. I mean, for OSPI 2, sorry, the written OSPI, how are the questions like one-liners, or are they like, you know, you have to explain them in an essay form? Like, how are the questions usually?
Yes, of course. If I thank you for the questions. Yes, for some questions, how did you they tell you what is the diagnosis, and they ask you in the next questions, why did you reach that diagnosis, and then why did you reach the, of course, what's the diagnosis? That will be one line. There is no differential here. Yes. So it will be one line, like this is an adenocarcinoma of the lung or metastatic adenocarcinoma in pleural fluid. So this is, for example, how the diagnosis is going to be. So that's one line. If I ask you, how did you reach that diagnosis? Then you will say, there is, for example, in the pleural effusion, you would describe that I saw a typical populations of cells with exhibiting high NC ratio, a prominent nucleoli, and a moderate amount of cytoplasm with papillary arrangement. This does fit with the morphological spectrum of adenocarcinoma. Okay, and this is, so that's like 2 or 3 lines. When you come to for example, what which molecular testing you will test for, and then you choose for, you will do the cell block and test for EGFR and ALK1 and PDL1, and then they ask you about the EGFR, for example, what is the significance of those? Then you say EGFR is of value in this and this. If they ask you about the methods of testing and which is the preferred, then whatever, if you do FISH, if you are going to say the preferred methods in our lab is FISH, okay, and you are allowed to say that because that reflects your local practice or regional practice, then you say the advantage of this is this. The disadvantage, of course, that it might fail, needs some cellularity, whatever it is. And then if you have a rapid gene sequencing, then you say 1, 2, 3. So try to, what I'm trying to say, try to make the advantages at 3 points and the disadvantages at 2 or 3 points, and that's it. So you don't need to write an essay. What you need to make sure in that you make it clear, and in a point format is good in this. When you are in the cytology exam, or in the, or if you are in the a short surgical or long surgical, you are not supposed to make a point format, except when you write your clinical pathological correlation or additional point. Then you can make it in a point format so it is clear to everyone. But in your microscopic description, don't do a point format, okay? Like in differential diagnosis book or something, when they write point format, don't do that. Write it as an, like what we write our real report, we don't write it in a point format. But for the OSPI written, I would encourage you to use the point format because it will be easier for the examiner to score you, and it will be sweet and short as well. Is that okay?
Yes, thank you.
Thank you. Any more questions regarding the OSPI 1 and OSPI 2? Please come up with questions. Don't be shy. This is why we're doing these sessions.
I just wanted to ask, is there any specific resources that we need to focus on, or it's just about common knowledge?
Yes, the good resources for the written OSPI that you, for example, you have to go to you know, if you go to the big society of which publish the guidelines, usually they will publish the iconic paper usually in the last 3 or 4 years. So if you, for example, if you go to the ISUP, for example, in neurology, and see the molecular guidelines, you will find the paper public, and usually it has got a free access for everybody because these are guidelines. So this paper, in any, if it's published in any journal, it will have a free access. And then this will be a good thing. If you write, for example, the guidelines for for reporting adenocarcinoma, even in Google, in lung pathology, you will find this paper. What we usually have as a trainee in UK, we know these papers because we get, like when we were, you know, we give it to our trainee, this paper. So we tell them there is the guidelines for BRAF has been published in this paper, but it's not difficult to find. What I would suggest is that you focus on the big 5 or big 6 molecular markers, because this will give you the idea. So for skin pathology, you need only to learn about the melanoma and the dysplastic syndromes. If you, for example, go to the GI, you need to learn about familial adenomatous polyposis and hereditary polyposis syndrome, and the mismatch repair. And then if you go, for example, to the breast, you need to learn about the BRCAs and the HER2, of course. And if you see, and the lung, of course, as we said, those molecular markers that I stated. So be very targeted. All what you probably need to do is to, even if you don't want to get the paper, although the paper are usually it's a summary of this, like it's 2 or 3 pages. So what we are talking about collectively, a 15-page to prepare for a whole part of an FRCPath exam, because you don't need to know the entire paper, but you just need to know what is the story is all about. So even if you get any BRAF paper melanoma and read it in 2 or 3 pages, any questions will come about BRAF, you will be happy to answer. Even if I ask you BRAF and thyroid, you will know what's BRAF because you know how to test for it and everything. So these are the resources for those. Unfortunately, for the management, there aren't sources available. But what you need to learn about management, about errors in pathology. So there is a document about errors in pathology. You will find it in the Royal College of Pathologists. How do we rank errors, for example? So if you want to take note of that and find that document, and they will classify the errors in pathology into 5 categories. You need to learn about the incident reporting, how incidents get reported as well. And you need to write about the GMC, how the GMC, the General Medical Council, investigate any errors. But you also need to learn about the hierarchical system in the UK. Let's not forget, this is a UK-based test, and we are expecting you to learn about the UK system. So I cannot, for example, you go and sit the IGCSE exam or the GCSE and the A-level exam, and then you tell me all what I know about history is the Egyptian history. No, the exam might ask you about the American and the British and French history, and you should know those by heart if you are taking history as a subject. So it is the same things that you need to learn a little bit about the hierarchical system in the UK. And if you don't know, I'm sure you have a lot of access to these discussion groups and things that you guys have formed. And just say, what is the normal hierarchical system in the department? Just learn this terminology and learn about the terminology of multidisciplinary meetings. Learn about that we face the mistakes. So the first thing that we do, there is a mistake, and we have to raise our hand. We have to think of patient safety. We have to stop the patient from, protect the patient from harm. Providing that this you start by stopping and putting everything in standstill till the investigation is complete, then you will be fine. You should all know by now, if we have a sample mismatch, how something like that get resolved, up from the level of checking the number against the slide and the requisition form. Then you go all the way to the DNA testing. So you should know how do we do we go around errors in pathology, which is a common thing to this mismatch scenario is not uncommon, and it does come every now and then in the exam. What I told some of my colleagues and the people who are sitting the exam, I for a long time now, I did actually an OSPI written lecture, but I never finished the final decoration. So if you really wishing to have it, I can try to make it available in the next day or two, and it will tell you it will give you a real feel of how the written OSPI will feel like, and just wish me luck that I can finish it. I already did it, but I didn't like formulate it as a slides, but I did it. But I can do that, and that might be helpful. So, and then I will publish it on the website. I can record it, pre-record it, and put it in the website on the YouTube channel, and then you can all access it. That's absolutely fine. So we can do that. But I think for the written OSPI, the easiest route is to get these iconic papers. And as I said, it's very easy to find. Just write society guidelines for BRAF testing. Whatever society are the most famous will come in the first line or 2 lines of the Google, and then you will find the linked paper and just get that paper and read it. So we are don't go mad. Just the common cancers. You see the common cancers that will get asked about, and this is what you need to know. Sometimes there was one of the exams we asked a little bit about cervical cancer, but cervical cancer we did ask about the new FIGO staging and things like that. So it wasn't really classic molecular, but majority of time we will be testing a little bit of half micro, half of the question is micro, and and this is to allow people to pass, and then the other half for the molecular knowledge. Yes, any more questions about this? Yes, unmute yourself, please, and ask the question if you have any questions regarding this area.
Dr. Ali.
Yes.
I have one question that basically all world, even all medical field is dominated by American books. While working in Britain or any part of the world, more than 90% or 95% books are Americans. And most of the people in the world, they are using the CAP protocols. So this is the same, but there are some differences between British guidelines and CAP protocols. Like, to be very honest, one of the wonderful resources like pathology outlines is American. US CAP courses are Americans. So people who haven't worked in Britain and they are experienced and they are using these resources. So how much difficulty they can feel in the discrepancy between the British system, as you said very correctly, that we are giving a British exam. So we are expected to know what is practiced or what is the hierarchical in the British system. So what is your experience or what are your comments to overcome this some discrepancy between the American guidelines and the British guidelines?
Thank you for the questions. Yes, I acknowledge this, that a lot of books are American, but this is because like sometimes you might find a book of a GI pathology that's written by the same 2 authors, but they publish it under 6 heading. So let's be realistic as well about this domination of the market, but that's not the issue here. The difference between the CAP and the guidelines and the data set of the college is is not huge and not marked, of course, and it is only in the fine details. But you will face a situation that we would expect you to mention for us the data set items which will score you brownie points, what we like to call it a brownie points, nearly in every histology questions, and nearly in the, and of course in the long surgical question. And sometimes you will come across it, and definitely you will come across the data set in the cut-up, in the macro sections. So I think the short answer that you need to learn the data set, and what it is that the data set of the Royal College, some of them are quite heavy and detailed, like the breast data set, for example, like the colorectal data set, and these are more comprehensive, much more comprehensive and in great details rather than the CAP guidelines. While other guidelines are very brief and direct to the points, like, for example, if you go by the some of the tumors in pancreas, or tumor in salivary glands, where you won't find a lot of major discrepancies between those. But what I then would suggest is that if you cannot sit the FRCPath exam without learning the data set, and the data set for us here is our Bible. And what it is, the first questions that, or the way that you will answer in the macro stations, you would say, for example, you've been given a colorectal specimen, a sigmoid colectomy, and then you would say, I will cut this based on the data set guidelines. So the data set states that we have to start by describing it, and these are the parameters. And what is important in this, for example, is the dimensionality of the tumor and the location and where it is, this synchronized or unilateral, multifocal, whatever, and associated polyps with it in the adjacent mucosa, associated inflammatory bowel that you can see, whatever. So, and then you say, the more crucial point, then I will block it in order to fulfill the major data set items. And this including the TNM classifications, which has to be included. So I need some sections to show this, to show that, to show this. And for the data set, we also wanted to see the tumor invasive front, for example. We need to see the inflammatory response. So you need few sections of those. You need to have sections for molecular testing that's well presented for a tumor. We need to see the adjacent mucosa, because if you are going to do, if you are working in a tertiary center, you probably wanted to compare the molecular markers to the normal adjacent mucosa to see how the discrepancy is. What I mean is that all of these things you will not learn it from the CAP, because the CAP are very direct to the point. The CAP guidelines always tell you, okay, this is what you need to do, this is blah, 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 but they don't explain for you why. The difference between the CAP and the UK data set is that the UK data set tries to tell you why. For example, when we argue against in melanoma between what's in transit metastases and what is the satellite metastases, so we have the explanations very well clear in the data set of the melanoma, but you probably don't have it very well clearly explained in the CAP. And therefore, then I would, even with the level of experience that you have utilized, let's say 15 or 20 years prior to sit the exams, reading the data set will be an asset, because it will add some information that we have, that is evidence-based supported, and they tell you, for example, you might get asked in the exam, okay, the minimum number of lymph nodes are in the colorectal resection are, and then, okay, everyone knows that it's 12. But then you will get asked, what is the UK average of the number of lymph nodes that you might get? And then the average number is 18. And then I asked you, and then I tell you, what would you consider it as a best practice? Then you say 18 and above in the average of 24 with a good specialist hand. And why is this? So the next questions in the cut-up, why do you need to get this too many number of lymph nodes? The answer for this you will find in the data set, but you will not find it in the CAP guidelines. So therefore, yes, it is, you will get asked directly, especially in the macro station, some question that's directly linked to the data set. And unless if you have read it and understood it, you will stand no chance for answering these questions, because you will start guessing. And the worst things to do in the exam is guess. And the worst things that you say, I am using the Australian guidelines, I'm using the American guidelines in my practice. Hang on a minute, you cannot say that, you're not allowed to, because again, once again, this a bridge-based exam. It are clearly, if you go to by the college guidelines, that they will be testing against the guidelines that guided by the college, and the guidelines, or the main one, is the data set. So I would say for the data set, it has to be read. The second part of your questions regarding the books and resources, yes, the books of the American books, I use it in my daily practice to diagnose. So we don't have any diagnostic discrepancy. It's all about just when we stratified the data set, we stratified it based on the level of evidence available, the best evidence available to support this. So if I tell you that we will do one mitosis for melanoma to do sentinel lymph node biopsy, then if you haven't read the data set, you might not know this. And if you don't know what is the Breslow thickness that will mandate the sentinel lymph node biopsy or resection, then you will not know this. So you will not know that from CAP. And you wouldn't know why we do this, because the best evidence showed that this is what it is based on that. So, and then this will be explained in the data set in details. Why do we do this? And how many of those we find. So the examiner is expecting you to say, for example, for the colorectal lymph nodes, you are expected to say that, yes, because if you go above, for example, number 24 lymph nodes, that doesn't carry a lot of difference in terms of prognostication for the patients. But if you compare the number between 6 lymph nodes and 12 and 18, you will find a huge discrepancy of the number of positively detected nodes, which might have a major implication on the patient management later. So it is the answer to be able to formulate it the way that I formulated it now. You cannot bring this answer unless if you read the data set. So as I said, the short answer is you have to read the data set and you have to understand it. And there aren't a lot of it. You are talking probably about around 12 to 13 important data sets. The amount of reading material within them, you are talking about 10 or 12 pages or even less, and some like in average 7 or 8 really important. Apart from breast and colorectal, we take those two out. And then you will not have a huge reading material into those. But going back to the things, the importance of it, because what will happen in the surgical question, that when you write, let's stick to the breast example. When you write it, you need to then link it to the data set. You need to link your core biopsy diagnosis to the data set, to the B categorization. And you will not understand the real B categorization unless if you read the data set, because it is simply mentioned into that. If you it's a very common case in the exam to give you one slice from a breast wide local excision or from a mastectomy specimen. So they give you a picture of one slice and they tell you, show me how you cut it. So again, once again, unless if you know what is the data set requirement for the breast pathology in the United Kingdom, it will be very difficult for you to select the block. But for the common knowledge, how do we diagnose? You can definitely use the American books, and there is nothing more superior than the American books, of course, in terms of knowledge based in because they are very systematic, and as I said, they are they are very clever in writing books, and this is how the situation is, and the reason why, because they have time, because they have an army working for them as a consultants, while in the United Kingdom, the consultants work in, they have to do the work for themselves. You know, they don't have people to work for them, like Epstein in America. He will have a group of 12 fellows and the chief residents and 20 residents working for him. We don't have that luxury. We tend to work. I would be lucky if I have a resident or two working with me at a single point of time. They will be distributed among the consultants, so I might have nobody most of the time. So this is why we don't have time to write books, but that's not the issue. I hope that I answered your question. So without
yes, I am. Yes, thank you. Perfectly. I fully agree. As I said, it is a British exam. Yeah. Even some of them, they have some training, some short trainings in USA like me. I have another question, if you please allow me. What about concepts of synoptic reporting? Yeah, like like synoptic reporting in different, like in breast or in colorectal tumors. So is it gaining popularity, or is it can this question be asked in the FRCPath Part 2 exam?
Can you just clarify what you mean by synoptic reporting?
Synoptic reporting means, like, as you said, in bullets. Like,
oh yes.
Basically, it's like the same thing. Instead of describing in a text or in an essay, okay, the criteria on which basically synoptic reporting is easy to interpret, can be easily interpreted by the oncologist. The next phase after the surgical phase, the oncologist or radiation oncologist or whosoever is the part of the team.
Yes, so, in general terms, synoptic reporting or bullet point reporting is good, and but it's not good for the exam setting. Right, and yes, for the exam setting, because you don't want the examiner to, if you get the diagnosis wrong, then what will happen is that the examiner will go up to your microscopic description to try to give you a mark based on what you've described. Yes. Did you describe the tumor as malignant properly? Did you identify the atypia properly? Did you identify necrosis or atypia or whatever marks? So the examiner will be going up to try to save your life. And what will happen is that if you don't stick to the essay format in writing, then if you get an answer wrong in the diagnosis section, then you have done no favor to yourself if you have a bullet points like you write lymphovascular invasion not seen, perineal invasion not seen, mitosis present or absent, and you haven't done a favor for yourself by that. So in the exam, I will stick either in the short surgical or cytology or the long surgical to the essay format. But yes, in real life, there are a lot of situations in England now that we use a pro forma format and bullet points.
Another question popped up. May I ask?
Yes, go ahead, please.
What is the level of cases of renal pathology? You know, the renal pathology is a very specialized, and most of the general surgical pathologists, they are not well exposed, and there are a lot of requirements, immunofluorescence, even certain cases EM. So when the renal pathology cases, they are put in the part 2 exam, so what is their level of difficulty? Second, in the same like hepatic pathology, okay, tumoral pathology or inflammatory pathology, and there are a lot of metabolic disorders which affect the liver. So may you please guide us or guide us that what is the level of this visceral pathology, particularly renal and
Okay,
hepatic.
I thank you for the question. Yes.
One more, because my experience as for a time, okay, we are seeing the more or less like renal tumors, urologic pathology, mostly tumoral related, but renal pathology, like in certain parts of the world, they have made the centers in which they are having nephrologists, nephropathologists, and with like more integrated facilities for a right diagnosis. So we need your guideline, we need your opinion.
Yeah, thank you very much for the question. The thing is that renal pathology is a major part of the long surgical exam. So you will definitely get hit 99% in every exam with a renal case. And let me again give you a short answer. First, the short answer is that the candidates in the UK, the trainee, the registrars in the United Kingdom, we allow them to sit, or we force them to sit the exam in the beginning of year 4. So that's basically after completing 3 years of training. Within these 3 years, they would have been exposed to a period of around 1 month in renal pathology. So that means 4 weeks. So how much you can learn in 4 weeks is how the exam will be reflected upon. I think the main things is that in the exam, in the renal exam, there are 2 major parts here. And the first part is that you are not supposed to make a full diagnosis like a renal nephrologist, but you have like 4 or 5 common patterns. And if you can tell me which one is this out of the 4, then you probably have passed the exam already. So if you tell me what I saw here is a membranous pattern, what I saw here is crescentic glomerulonephritis pattern, or what I saw is mesangial pattern or focal and segmental glomerulosclerosis pattern, then that's enough. That would have passed you the exam, right?
Yes.
So you are not by default required to give a nephrologist type opinion in your answer. But don't forget, and this is I keep telling to our trainee and registrars as well and fellows, that you will be given the electron microscopy picture in the exam. And the electron microscopy, even for the best nephrologist in the world, is something that will be in his hand 6 weeks down the line. And if you really wanted to answer and make sure that you answer the question correct, what you probably need to know is to learn a little bit about the electron microscopy, what the 4 or 5 pattern looks like. What I mean, what if the membranous with the deposit looks like? What if it is mesangial deposit, how it is going to look like? What is the difference between the deposit within its subepithelial or subendothelial? What is the difference if it is crescentic? And if you know that, if you can read the electron microscopy, they are A, B plus C equal D. If you know how to read it, you will reach a diagnosis in the first minute or the first 2 minutes of your 20-minute And then all what will happen that you will put the special stains and the things to confirm. In a lot of people, as soon as you know it is already crescentic glomerulonephritis, all what you need then to say is to put the proforma that you have in mind. So if you know what to write when you have a crescentic glomerulonephritis, what I mean by you know the different part of the question, how you describe the crescent, how you describe the endothelial cells, how you describe the epithelial mesangial cells, how do you describe the blood vessels, how do you describe the tubules, how you describe the interstitium, and how you describe the special stain. Providing that you show the examiner the format, then the format of the report, then you will be safe. So renal cases are not really difficult as everyone thinks, because we are talking about 5 patterns with a lot of differential underneath them, but that's not the issue here. The issue, they will tell you already the patient has got, they give you the history. So you already know the patient has got nephritic or nephrotic or hematuria in the question. That's not the issue. The issue here that you're being given an antibody that is shining for IgA, and you saw that this is a mesangial proliferation pattern, then write it. This is a mesangial pattern showing IgA on immunofluorescence, and then it's IgA nephropathy, and that's it. Why do you think this will be difficult? The level is easy because what we are asking you is a pattern, not to sit in the chair of the nephrologist. And what also makes it easy, that I am giving you the answer in the EM picture. If you didn't bother to learn the EM, then you didn't really take the exam seriously. And to learn the EM, it only will take you a day or two, because all what you need to learn is 5 or 6 pictures. And then you go to the exam, you put these 5 pictures in your mind and you picture match them. And this is how you reach the diagnosis. So I know, and the same for liver, that you will have to say lobular pattern. You have to say this is, for example, a portal inflammation pattern or acute inflammatory pattern, and then that's it. You don't have to tell me in details. For example, I will give you an example from my own exam. My own exam, they told me in the question that the patient have hepatitis C. So all what I need to say, yes, I saw hepatitis C pick a format in the chronic format of it. And then I tell them if I see cirrhosis or not. And then I put all the proforma of the other stain that I put the copper stain, I didn't see copper. I put the iron stain, I didn't see iron. I put the PAS stain, I didn't see alpha-1 antitrypsin. And then in the clinical pathological correlation, you say, okay, it doesn't look so severe, the inflammation, the stage looks early or moderate, and that's it. So I think the problem is, I will tell you what the problem is. The problem is, it goes back to what you've stated. You're trying, for example, to read the entire renal pathology book to prepare for the exam, but you forgot one thing which is very important, that what we are asking you about pattern. Tell me, I give you the answer up. Do you see it down? This is what I do in the liver case. This is what I do. Even when I give you a hepatocellular carcinoma in a tumor pathology case, I give you a liver with a tumor. What is the first thing that should come to your mind? It is hepatocellular carcinoma. If you don't say hepatocellular carcinoma, then it's your mistake. But then if you saw it as adenocarcinoma and you are calling it hepatocellular carcinoma, and you ignore the fact it might be cholangiocarcinoma or metastatic, then it is your mistake again. Okay, so yes. it was a common case. That was a live case that came in the exam before. A patient had a prostatic carcinoma, and they gave a case of pancreatic cancer, right?
Right.
And with the immunostain, right? Some CK7, CK20, very non-specific type of stain. It
Yes.
was a long surgical case. So for those who ignored the fact that there was an IPMN in the background of the pancreas, and that's most likely going to be a primary pancreatic tumor because you saw the local or the focal dysplasia, which should be the precursor for the cancer.
Exactly.
And anyone mentioned that this is metastatic prostate was wrong.
Correct.
Okay, and failed the long case. It didn't need, a case like this didn't need a hepatobiliary pathologist to answer this. But all what it needed, it is a common sense. Did you see the obvious, right? I will tell you another case that people failed on the exam of a liver, a case of hepatocellular carcinoma, and the people failed on that case, although they said it's hepatocellular carcinoma, because they failed to look into the PATH stain to see the alpha-1 antitrypsin, which was all over the place. That means if you don't know what alpha-1 antitrypsin looks like, this is a medical school type case. That's not an FRCPath. Then how would you dare to set an FRCPath without looking into what alpha-1 antitrypsin globules looks like?
Yes.
Okay. So in terms of, don't dig deep in the knowledge, stay at the periphery. Don't try to get a 500 text and read it, because you are asking for the impossible. And as you stated clearly, I will tell you, the problem is that when people use pathology outlines, there is no format in it. So they don't know what to read, right? But what's really needed, that if the easiest question is, ask your renal pathology colleague, give me the top 6 diagnoses that you come across every day. Those top 6 are the top, one of them would be the one that will come in the exam. That means that all what you need to know to learn is 6 diagnoses. Is it that hard? That's not hard. Okay.
Yeah, wonderful. I appreciate. There is another question. What is the?
Can we ask other people now?
Yes, please. All me. Yes.
One question.
Yes, please go ahead.
My question is that we are only some 15-16 days away from the exam. So what will be your last minute advices for the examinees, and also especially for the exam day? Can you please advise us some things, because you always give us very good tips.
Okay, thank you very much for the question. So the first things is I would advise you to do, if you have not read the data set, you have to read it, right? So this is, if there was one thing that you have to read, it has to be the data set. Yes, if you have not read it before, right? Because that will make your life much easier in the exam at all levels. And usually, so that means that you will dedicate a day for every data set and you will read it, and that will be your final prep. But if you've read it, then the things that what I would suggest for people to do, that in the 2 days before the exam, never to read anything at all. Even if you are one of those people who tends to try to read in the last minute, don't, because this will mess your brain up, which means that you might get a case of a soft tissue, but because you just read about, let's say, rhabdomyosarcoma, then you get a case of rhabdomyosarcoma on a frozen section, and you say, because you just saw it in the night before the exam, you tell the examiner in the frozen section, this is a rhabdomyosarcoma, which is a crime, right? Because all what you should have said, this is a spindle cell lesion with atypia, probably malignant, I will defer. Okay? So you say this, I will defer, you give the diagnosis and you defer, as this is the meaning of defer. You don't defer before you give a diagnosis. You give the diagnosis and you defer. But if you go into the station and you say, then what will happen in a frozen section that the people will tell you will start making a joke of you. They will tell you, so you can diagnose a rhabdomyosarcoma from a 2 millimeter biopsy that's completely distorted by all the frozen artifacts, and you know it is rhabdomyosarcoma? You sure? You sure that's not, for example, a fasciitis that's infiltrating into skeletal muscle, and all what you saw as rhabdoid cells might be degenerate skeletal muscle? Okay, so all what you say, then what I am worried, and I always, we see this day in and day out in the exam, people who just read something, it's the first thing that comes into their mind, and they tend to forget about the approach. What you've learned over the years and the months before when you were preparing your pathology is an approach. When you prepare a day or two, or you try to revise everything a day or two, then this mess up your brain and make you jump for a diagnosis rather than using approach. And this is a very dangerous game to play. This is number one. Number two, if you really, really wanted to read something, then read something that's not going to do something. Yeah, I will tell you something I did. What I did in the night, in the day, not the day before. Of course, I booked a very nice hotel next to the exam center, and I opened, as soon as I entered the room, I opened the TV and I kept watching TV program. And while I was doing this, I kept practicing for half an hour sometimes on the speed of how I formulate a table of immunohistochemistry. Like, for example, if you get a malignant spindle cell tumor, how do you write the table? How quickly you will formulate the table, because the times matter. And I was only practicing on the speed. You see, so I was putting the stopwatch and practicing on the speed. How do I write the table of round blue cell tumor? This is all what I have done in the 2 days before. And anything else don't. In the week before, never allow any new information to enter your brain, because this will be very dangerous game again, because anything will come as a half a knowledge. And the most dangerous things to enter the exam is you have a half a knowledge. It is better not to have the knowledge, because if you don't have the knowledge, you will build the approach and you will pass the case. But if you have only half of the knowledge about the case, then you will mess it up and you probably will lose the mark for it, rather because you would have left the approach behind. So this is another thing. But there are, in the day of the exam, I would recommend that for you to take, of course, your own microscope, or the microscope which you use in your day-to-day work with you, because you are very familiar with it. I also recommend that you take a ruler that you can measure a tumor on a slide or a tumor on the macro station, because it will be good to give some real measurements sometimes. If you try to give us some measurements sometimes, if you can, take some cytology slides with you. And I tell the people always that if you are going to, the first station is the cytology, and because majority of people take like 5 or 6 days leave before the exam to travel to the exam centers or to go somewhere, then they tend to spend like a week sometimes without looking into cytology slides, which are not available online. Then your eyes are not calibrated to the cytology slides. So make sure that you take a bunch of slides with you. So in the days before, keep looking into those cytology to keep your eyes well calibrated between the different types, what the lymphoid cells looks like, what the malignant cells, what the mesothelial cells looks like. Because in the first 20 minutes of the cytology exam, if your eye is not very well calibrated, and you started, for example, by a difficult cytology fluid because of you're unlucky, then you tend to you mix them up, and then you till your eyes get calibrated, and by the time your eyes is calibrated, takes about 6 or 7 minutes, and then you lost already one case. You probably lost one case, and you might have got it wrong, standing 50-50 chance. So I would recommend that you take the slides. They allow you, of course, to sit and calibrate your microscope in the day before and in the morning. So you sit, and I tell people, if you want to do prayer, do it at home before you leave, because when you sit in the station in front of the microscope, don't do the prayers, calibrate your eye, put the slides on the stage and keep looking at it, and then put it in these boxes, and then put them back in your pockets, and your eyes is well calibrated, and you are absolutely fine. Okay, this is even before the examiner come into the room or anything. You just enter and do that, and then you don't lose this 4 or 5 minutes till your eyes is calibrated. The cytology, we usually recommend for people to take the X2 out, the X2 magnification out of your microscope, take it out completely, dislodge it, and take it out, put it on the side, because you don't use it in cytology and you will be wasting time with it. So only start always from the X4, X10, so that will save you possibly like 30 seconds per case, and will make it a little bit more harmonious and more flexible. Now, what I for those who are going to sit the exam in 2 weeks' time, I cannot tell you in the cytology, you have to go systematic, like you write your microscopy, your diagnosis, your differential, your additional test, and then your discussion after. These are the 4 blocks of your answer. But before you, but for the histology, I tend to tell people to write it in a different format, like leave a page for micro, and jump for the diagnosis, differential diagnosis, additional test, and then go back to the micro and write it, because you don't want to run out of time. But in the cytology, you should write it systematic. But if you, the reason why, because when I invigilate for exams, I find people spending like a page and a half trying to write the most beautiful microscopic descriptions ever been made, and they run out of time. So then they find your diagnosis box and differential diagnosis and the additional point, which will score you the points, are like 1.5 lines because you're running out of time. Your micro description will not score you, right? So even if it's brief, if you know that this is adenocarcinoma, then all your micro description, this is a complex glandular proliferation with atypical cells showing some mild to moderate degree or moderate to severe degree of pleomorphism of prominent nucleoli, increase-NC ratio, full stop. And then I move. What I tend to do as well is I leave a page after every question, because there is a lot of calculation will happen in your mind. What I mean, especially in cytology, because you have 8 cases, you might have 2 difficult cases that you're not sure. You are borderline, benign, malignant, benign, malignant. And then you mark them. And then once you came across a second case now, you will have to choose which one you will sacrifice to try to save your life. Okay? So the only way that you will be able to save your life is to go back and modify the answer. So don't try to jumble up the answer. Write your microscopy, even if it's taking 3 lines, leave the rest of the page and move to the second page and write your diagnosis, and then move to the second page and write your additional work, and then the 4th page. So you are leaving like half a page empty in every one. So if you ever changed your mind, you have a lot of space to play with. You probably, all what you need to add, the word no. You see, like you said, there is a pleomorphism, then you say no pleomorphism, no mitosis, no whatever. Then you write the word no, 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 no. And then you completely converted the answer, even if you have 1 or 2 minutes left and you change your mind. It is not uncommon that people will change their mind about a case in the last 5 minutes and of the real exam. And the reason behind it, because you said, I am wrong now in that case, or I was borderline in that case. I am borderline in this case, but I have no clue in that one. Which one should I sacrifice and which one should I confirm now the diagnosis? Then you should choose, because you are not allowed more than 1 wrong and 1 borderline in the cytology exam. 2 wrong is fail, okay? So 1 wrong and 1 borderline, and that's it. So there is a lot of calculation will happen. But my ultimate advice to you is the minute that also you sit on the exam, there are 2 things you have to put them on the in the question sheet or your answer sheet. Don't guess and don't push for a diagnosis. If you don't think that this diagnosis is correct, then don't put it. Just use the approach and don't guess. Don't think, oh, it's most likely going to be this. Well, I think it came before 3 times in the exam. Don't do that. Don't play that game. It's either you know it or you don't. If you don't know it, write the approach and stay safe, and you will be absolutely fine. But if you guessed or you're trying to push a diagnosis, although it doesn't fit, but then this is when the extra knowledge, yes, but I saw, some people say, I saw 3 cases which never, like a solitary fibrous tumor, which didn't have these staghorn blood vessels. But in the exam, the case of the solitary fibrous tumor has to have a staghorn vessels. If it doesn't have a staghorn vessels, then it's not solitary fibrous tumor. Although your experience say, yes, I saw a lot of examples without, but your experience here is against the exam. I told you this is this is year 4 level exam in England, and therefore the cases are classic, right? Classic of the entity. They are classic of the entity. Sometimes they are classic of the entity, but in an abnormal place. Like we give you a glomus tumor in the GI tract instead of a glomus in the foot, right? So then it becomes unusual place for this tumor, small cell carcinoma in an esophagus, which is not usually get seen. But this is a different story, but it's still on its own right, it's a classic case. The other things which I would suggest you to do is in the day before, between the 2 exams, don't revise at all, because you are already very exhausted and very tired. And the moment that you will sit and revise, I can reassure you that the next day you will be damn exhausted, damn tired. You won't be able to answer the questions as you wanted, and you will get mental blocks with a lot of cases. So don't. Your mental health and your physical health is the most important things. And eat properly and enjoy your life in the night between. I told you all what I did. I had a luxury dinner in one of the restaurants near to the hotel. And what I also did in between the 2 exams, I sat down and watched TV and then I slept. This is all what I did.
Okay, Dr. Ali, I just wanted to ask about the TNM staging. How extensively do we need to know it, and do we need to memorize it in detail? For example, small points in differences in A and B categories, not in 1, 2, and 3 sort of things.
You in most of the surgical exams, you don't need, in most of the written answers, you don't need to know it. But sometimes in the OSPI, they might ask you, because it is not in the OSPI, in the macro station, they might ask you because it is of a great significance. Like, for example, they might ask you, how do you TNM a colorectal cancer? You should know, right? So you should know that in the early stages, when the tumor is in the mucosa or the submucosa, in the mucosa, it would be T1. If it is passed into the muscles, T2. It's passed into serosa, it's T3. If it's perforated the serosa, it's T4. So if you are to be asked about the TNM, you will be asked about the common one, right? So they are not going to ask you about a very rare one, but in principle, for example, if I ask you about TNM of thyroid or salivary glands, you should know that in the early stages, we categorize this tumor based on the size. This is how you will answer it, based on the size. Some tumors are up to 2 centimeters, some tumors are up to 3 centimeters. And then in the T2, it's between 2 and 4. And then in the higher stages, if it is above that in terms of size or start to invade into other structure, this is when T3 and T4 comes in hand. So if you ever get asked questions about a TNM, you should tell them the principles of that TNM. If, for example, in the renal, you might not remember what is the renal tumor TNM, but you know that in the early stages, it goes by the size. And in the more advanced stages in T3 and T4, it goes by the involvement of the renal sinuses, renal vein, and then the invasion of the surrounding structures. So always make the answers as a principles. You say the principles, or you can say the whole entire TNM is not clear in I don't memorize it. You can say that, you are allowed to, but you then say, but the principles are, the principles of the FIGO staging of endometrial cancer is, you see, you should know that. These are the common knowledge and you should bring it into the equation that way. But yes, by heart, you don't need to know the exact details. Thank you. Any other question, please?
Yeah, can I?
Ali, can you?
Yes, please.
Dr. Ali, can you please tell the important specimens that can come up for macro?
The types you mean?
The important specimens, like for macro, like breast can come, like.
All right. Yes. Yes. I think the rule is, of course, that anything can come, but the common ones that can come in the exam, of course, you know, the nephrectomy specimen, colorectal resections. Almost always, you will have one of the cases of colorectal. The lung keeps on coming every year, yes, and year no. So this is how they play that. The difficult one that rarely come, like every 3 or 4 years, are things like the limb, like a femur with a bone tumor or a soft tissue tumor. And the reason why, because they want you to have read how people sample it, because it has got a lot of chemotherapy implication, and how the blocks are taken in a systematic approach and things. So this, and of course it's easy for margins, but it is difficult for how it's blocked to see response for chemotherapy. And majority, as you know, of soft tissue and bone tumors will have an adjuvant treatment prior to an actual resection to try to shrink a tumor and decrease vascularity. But in generally speaking, breast comes every year, yes, and year no. So I would say it is difficult to put your hands on them, but I would say out of urology, definitely you will either get a kidney or a testis. So this one of them will come. In the lung, if the lung comes, it usually will be lung tumors with some satellite, and you have to show the relation to pleura, show relation to how you will deal with the satellite, how you stage satellite, how you deal with the bronchocentral area to the hilum. So all of those are important, the hilar nodes and things. So all of those are important because there is a lot of margin would be involved at this level to do with the lymph node margins, as well as the bronchus margin, the arterial margins, and so whatever these margins in the hilum. So for example, prostate will not come in the exam, prostatectomy. bladder tumor doesn't really come in the exam because these are very, very highly specialized type specimen that they don't come. So what I mean, you might, but what on the other hand, there are some other specimen that tends to pop up in the exam every year yes and year no, like a larynx. So a larynx is another very important one that you have to be ready and prepared for, because it does come. So if you are to tell me out of the entire head and neck specimen, thyroid, salivary, what will come, I will tell you the larynx. It is the commonest one that does come in the exam is the larynx. If you get a breast specimen, as I told you, the breast specimen will tend to come as a slice, and then it becomes easy because you don't give you, of course, a picture of the entire breast. They give you only one slice, and then you say, well, this slice, obviously, it's one of the mastectomies. It's showing this tumor XYZ, and it is located near to the anterior margins, posterior margins by this. And you describe the exact tumors, and then you start telling the examiner how you will sample this. So what I mean is that what is common in the macro station. I think the most difficult one from my experience with these are the bone one, because especially for those who don't do soft tissue and bone. So I think you probably need to know how it is done, especially if the patient had a chemotherapy, because it will be a huge bonus if you say exactly how the specialists do those. And then on the second most difficult one, I think, is the larynx. But apart from those two, I think any other one is easy and straightforward. Either it's a cecum, it is a sigmoid colon, it's anterior resection from a bowel, a radical orchidectomy. These are all easy. Even lobectomy or a lung case, this also will be an easy case. So I think what is common is common. If you want a short answer again about this, it is like our day-to-day, apart from the larynx and apart from the bone. Yeah.
Also, Dr. Ali, you said we need only 12 or 13 important data sets. Which would be those, like, to give priority?
Well, I think it is to do with you know, if you will probably wanted to ignore things like the soft tissue data set, because there aren't any difference around the world from the soft tissue point of view. We cut it like the rest of the world. We do it like the rest of the world. If you go to the basal cell carcinoma and squamous cell carcinoma, it is still the same. We look into the depth of tumor, the Clark's level, and then lymphovascular invasion, perineal invasion. You don't waste time into those, but if you are to go, you choose the one for melanoma. I will read the lung one, pancreas one, colorectal, breast, and kidney for sure. I will not be quite excited about the head and neck, but I will read the thyroid out of the head and neck data set, for example. So thyroid data set will be one to read from the head and neck. Breast, by all means, you have to read. We have two data sets for breast, one for resection and one for the biopsy. Both of them has to be read. As I told you, the colorectal, the pancreas, liver data set is not really different from the rest of the American guidelines, or nothing will be added a lot in this. So in general speaking, you are talking about the major systems. So if you are talking about skin, I will read the Merkel, and I will read the melanoma. If you are talking about the renal, I will read the testis, and I will read of course, the kidney one. If you go to the gynae, I will read the endometrium, because that is the one that really matter. If you go to the lung, it's only one for lung. And then if you so go system by system. As I said, don't try to, for the major system, it's only the major system. This is what you wanted to go. So you will be talking, yes, about 10 or 12 data set. The most important one that you will be using a lot will be renal, endometrium, melanoma, adrenal gland, and the breast and colorectal. But yes, adrenal gland is one of the very important data set that you will be using it intensively if you get an adrenal tumor in the exam. Without the data set, you will probably not score high in the quiz.
Dr. Ali, I have a question.
Yeah.
Just as you told us about the macro, can you just let us know about the common cases that come for frozen section and the drill of the frozen, just for candidates outside UK, please?
Well, let's always stay by the basics. What is common is common. The question will be always, in every case that will come in frozen, is 3 type of answer that you will have a choice. Either it is absolutely benign, either it can be benign or malignant, you don't know, or the third one, it is absolutely malignant. But when you go to the absolutely malignant, is it malignant that you know what it is, or is it malignant that you don't know what it is? Like, for example, spindle cell tumor, which can come in any part. They might send you frozen section from a breast with a spindle cell tumor. They might send it from a retroperitoneal tumor, spindle cell tumor. They might send it from an arm, spindle cell tumor, from an uterus, spindle cell tumor. Okay, so whatever it is the same things, the same scenario that will be applied everywhere. The same for granulomatous inflammation. It is one of the cases that will pop up in the frozen section, and you need to know how you will approach something like this. What are the precautions that you should take in a lab when you get a frozen section with a granuloma? How you're going to sterilize your lab after, because this is a point that you have to mention. There is other cases which come to try to confuse you between, for example, an implant. If you have an implant of something, of a tumor, either a benign or malignant implant in ovary case or in an esophagus tumor case, then you need to know what does the normal peritoneum look like, and what is the definite adenocarcinoma will look like, and what is the definite no, I don't know looks like. So there are always 3 choices. It is anything can come in frozen, but what it is that we target a certain area. So you have to be ready when you get a granuloma, what you are going to say. You have to be ready when you get a parathyroid gland in the frozen section, what are you going to say? You have to be ready when you get a small round blue cell tumor in a frozen section, what are you going to say? You have to be ready if you don't know the answer, how you are going to manipulate that, right? So you have to have a scenario ready for everything. You have to know when it is benign, that it is benign. If I give you a margin, and you don't know, if you don't know the margin, if it is benign or malignant, then it doesn't have in between. If I give you a pancreatic duct margin, or I give you a ureteric margin, it is one of these cases, it is black or white. It is either yes or no. There is no third answer here. But there are cases of granuloma. There are cases which only show reactive atypia, but you need to defer it. You think it is reactive atypia, but you need to defer it. There will be cases which will be an abundant cancer, like an endometrial cancer in the ovarian specimen or serous carcinoma in ovarian specimen. And there will be cases of a margin that's positive, and there will be cases of a margin that's negative. So in generally speaking, there will be margin specimen. Yes, there will be a pancreatic frozen. Yes, there will be a bladder, margins, or yes, there will be a granulomatous inflammation somewhere. Yes, there will be a spindle cell or round blue cell case. Yes, and there will be an entirely benign case. Yes. So if you want to play, these are the expectation, but how many of which you cannot play that game, right? What I mean is, can you get 3 malignant and 2 benign and 1 you don't know? Yes. Can you get 3 benign and 1 malignant and 1 granuloma and 1 something else? Yes. So you cannot play the game. 3 of them are malignant, then the other 3 has to be benign. Never play that game. Okay. Yes. Thank you. Any other question, please?
Dr. Ali, I have a short, actually I will try to sum up.
Yes, but we need to give to everyone a chance. We need to give to everyone a chance for questions.
Okay. Inflammatory dermatopathology, and what is the extent of neuropathology?
Okay, we'll come to this, but we need to give a chance for other people to ask.
I agree. Right. Yes.
Yes, please, other people, would you like to ask questions? Any other participant, please? Sorry, you need to unmute if you're asking questions.
Yeah, inflammatory dermatopathology.
No, I know your questions. Yes, no, we're asking the other participant first. So if other participant, please, if you have questions, please ask the question, please.
Dr. Ali, in long cases, are there particular systems from which, like you said, 1 renal, 1 liver, like, are there particular systems from which the long cases come?
Yes, the long cases has to have a renal case every year and has to have a lymph node every year, right? I mean lymphoid case. So the half of the exam every year has to be a renal and lymphoid, right? So this is in the long cases. Then the other 2 will be a tumor with a differential, which can be a soft tissue tumor sometimes, or it can be a metastatic tumor that they wanted to see you approach like a polydifferentiated tumor of some sort. So the liver will depend. If the liver is to come in the short surgical, then it will not come in the long surgical. But but if it comes in the long surgical, then it will not come in the short surgical. If it doesn't come at all in either in the long surgical or the short surgical, it's most probably then it will come as a case in the frozen section, like a bile duct hematoma or a bile duct adenoma or something. Okay. So this is how the liver will be tested, but you will not be hit with the liver more than once. If the liver is to come in the long surgical, it will be an easy case because they will give you the answer in the heading. So they will tell you that this is a case of hepatitis B or hepatitis C, or a case with iron and overload and the other features of iron. And then all what you need to see is hemosiderosis and cirrhosis and whatever, and just describe what you see. So for the soft tissue case, the long case, it's not necessary. For the renal case, I briefed this at the beginning. For the other long case in the soft tissue, for example, you might they will give you, of course, 5 immunohistochemistry, but you might not be able to still reach the diagnosis with those 5 immuno. So don't panic if that's the case. All what you need to do then to just try to tell us if it is a high-grade spindle cell tumor with some specific features like staghorn vessels and fascicular pattern, for example, and then give me a short differential of what you really think it might be based on what's common is common. So don't give me the tumor that you only saw it once in 1,000 years. Just give me what's common is common, and then give me your immunotable, how you will resolve the conflict. The same things for the lymphoma case. Sometimes the immuno might not resolve it for you, but it will narrow the differential. What I mean, it will narrow the differential. It will tell you, I am a high-grade B-cell lymphoma, or I am a Hodgkin lymphoma, yes? And then you need sometimes an additional immunohistochemistry to be able to finalize the case, because in majority of cases, 4 or 5 immuno might not be the enough, and that's targeted by the examiner. They are targeting this to see how much you can give. Don't forget that you only have 20 minutes to show me the knowledge, what you have learned in 5 years about lymphoma. And you might never work in lymphoma again. You might become a breast pathologist for the rest of your life after the exam. Then in these 20 minutes, please show me the knowledge that you have learned about lymphoma. Don't be a single answer type person. Don't try to tell me, oh, this is a lymphoblastic lymphoma. And then you forgot that the lymphoblastic lymphoma has got differential diagnosis of the lymphoblastic variants of mantle. It has got diffuse large B-cell lymphoma as well in the differential. So, and you need to do an additional immuno, additional history taking, additional molecular to be able to stratify this tumor, because all what you have done is you learned in the night before the exam about lymphoblastic lymphoma. So you saw this looks like what I have seen the night before, then it's lymphoblastic lymphoma based on 4 or 5 immunohistochemistry slides that you've been given. You're not doing any favor for yourself by doing that. You're committing, you are showing actually the examiner that you don't have an approach, and the long cases is all about the approach. It's not about the right or wrong, okay? It is about that you showed the examiner that you have approach, you created a differential, you favored something in the differential, and then after that you've said you solved the problem. You didn't stand still. You have solved the problem, and you said the problem now is this, and this is what I have, and this is how I'm going to resolve it to give you the answer. Okay, so yes, I can give you half of the exam. Half of the exam of the long surgical will be 1 lymphoid case and 1 renal case, but the other half can be variable. Sometimes it can be a testicular tumor with immuno to tell me the different types of the teratoma that's present in that tumor based on the immunohistochemistry that you've been given. So it can be something like that. Sometimes I give you a phylloides tumor, malignant phylloides, but with rhabdomyosarcoma or angiosarcomatous differentiation. So you need to have read the immuno to exclude, of course, the metaplastic carcinoma, and then subsequently you diagnose it as phylloides tumor, but you also diagnose it as heterologous component of angiosarcoma that you see it in the background of phylloides. So sometimes the surgical or the long surgical cases might be targeting in areas like this. Is that okay, answering your question?
Yes, thank you, Dr. Ali.
Thank you. Okay, next question, please. So for people to ask questions, you need to just unmute yourself to ask the question so we can hear the question. Thank you. And don't be shy. It is your opportunity to listen to to ask questions here, and I will be happy to answer them.
Dr. Ali?
Yes, please go ahead.
For the long case, will it be all slides or pictures, like for liver, renal?
Yes, thank you for the question. The renal case, they will give you the H&E as a and the special stains as the slides, and then they will give you either the histochemistry of the immunoglobulins and or the immunofluorescence equivalents as a pictures, and then the EM of course will be a picture. So for the liver case, they will give you all slides. So the only situation where you will be faced with pictures in the exam will be in the immunoglobulins of the renal case and the EM picture. And you will have, of course, in the frozen section, yes, not the frozen section. The frozen section are slides. You in the cut-up station, the macro stations, you will be given 4 pictures to draw on them. So you're being given the pens, the board pen, which you can draw on the laminate paper with, and you will be given a booklet. You can write in it, and you will be given pens that you can draw with different colors if you wish to draw your blocks, how you take the blocks. So these are the situation where you will be faced with the pictures.
And for the long case, we write all the answers or do we discuss it as a viva?
No, in the long case, it's all written. The problem which you might face in some situations, and this is good things to remember, you still use the same format of the answer, like my microscopic description, my diagnosis, my differential diagnosis, if you have any, your additional work that you might want it to include, and then the final part, which is the discussion for the Brownie point or the CPC correlation, which must be included in the long cases. You have to, or you will lose like quarter of your answer. 5 marks will go away if you don't write a proper CPC in your answers, because it is part of why we call it long case. So you give us a CPC. So you have to correlate it with that history you're being given. However, there is an important point that some centers might take the question with the slides when they give you every question with every head of question with the slide, and as the 20-minute passed, they will take the head of the question with the slides to give it to the next candidate. So you might lose that heading of the question. So if you run out of time for the CPC, it will be very difficult. You can't go back. In some centers, they might leave it if they have enough copies for the heading of the questions, but in majority of the centers, they won't. And that means that I would prefer you to write your CPC first before you write your micro or your diagnosis or anything, because if you want to go back and write something, the only thing that you will be very difficult to go back to correlate it to the history that you've been given, because that history won't be in your hand again anymore. So that's just one thing. But yes, it is all going to be written. There is no OSCE about the long case. Right? Next question.
Thank you. Thank you.
Dr. Ali?
Yeah?
Yeah, could you tell us how do we prepare for frozen section and cytology, please?
Right. It depends when you are going to sit in the exam, of course, but the ideal preparation of frozen section that you have to choose a book, choose one of the books that available, the Americans, yes, which are the same like the Brits, by the way. But yes, choose one of these books and dedicate that you will read it. You will read it read it from cover to cover, and that will be the book that will give you the basic knowledge of how the frozen section will work, right? So and then the recommendation will be to use the shortest, really. So if you really wanted to use, you can use that biopsy, one of the biopsy series for frozen section. You have that biopsy series for everything. So the biopsy series for frozen, you can use that. It's very easy to read and simple. And what that will create a good base for this. The second thing is that you will have on the Leeds website a lot of frozen cases. I think they have like 100 cases or something. So you can test yourself on them. So just open the case without knowing the answers and test yourself on those. And then try to then attend sessions or seminars or courses that discuss this area to give you the fine lines. Like the fine line, what I mean by if you get a granulomatous inflammation in a frozen section, how you will formulate the answer. It's not enough to say granuloma. You have to say we are faced with a situation because there is occupational hazard to the lab, to yourself, to the people who worked with you in the cut-up room, how you will protect the other specimen from not being contaminated, how you will do things around this. So this has to be included as part of your answers. So what I mean by that, there are some format answer that you need to know. If, for example, someone to send you parathyroid, and then they try to pressurize you to say, is it adenoma, is it hyperplasia, is it carcinoma? You cannot answer that from a frozen section. All what you say, this is a parathyroid gland. It looks hypercellular, but that's about it. And you cannot say anything, any single word more. Even if they kept pressurizing you for 3 minutes, fighting with you to try to grasp an answer, don't say, I cannot tell you anymore. I'm so sorry, I cannot tell you anymore. So what I mean by this, that there are scenarios which you have to memorize and remember and regurgitate it during the exam. And this will come by attending a lot of exam preparation sessions, courses, listening to other people, chat room, talking about their experience with it, what they did do wrong, why did they fail sometimes in frozen cases. So all of this are it's a build up knowledge, but you have to have a book that has built up the basics so people don't brainwash you, because you can always refer to a book, but don't go mad about other books. If you want to navigate a lot of books, just navigate them as pictures, but don't navigate them as reading, because if you cannot, it will create conflicts and confusion, because you can see Mr. Smith saying something and Montgomery saying another thing, and Fisher saying another completely different things, and then you start getting confused. So get one source, build the basics, and then get the other people experience into the build-up. So that's for the frozen section. What's the second part of your question? Sorry, there was another part.
Yeah, about the cytology.
Cytology, it is the real way to prepare for the cytology the preparing for cytology in the past was difficult, and the highest rate of failure in the exam of the FRCPath every year is cytology. So nearly half or more than half of the people who will fail the FRCPath every year, they are failing mainly on cytology. And this is because the range of failure is low. Like you get 1.5 case, you fail after that, right? So this is why you fail. You get one case wrong, you are on the borderline of failing. This is how it is. And the preparation for cytology, number 1, number 2, number 3, you have to give yourself time by seeing a lot of different types of preparations and cytology slides. I would say if you want it by number, I always tell people you need to see 3,000 cases of cytology to be able to be ready for the FRCPath exam. Either you see them in courses, you see them on the internet, you see them wherever way you wanted to see them, you need to see around that figure, and because that will, when your eyes now will be calibrated and tuned for what's really malignant, what's really reactive, and what's benign. The problem is that there is no one book as a good book, and because of the vast area that comes, but you need to read in depth some the most difficult cases. The people go wrong in the exam because they fail on the fluid cytology and urine cytology historically. The thyroid cytology is easy. The pancreatic cytology is easy because the cases will be really malignant if they are. And the biliary brushing is like that as well. And lymph node cytology is easy as well. So the real difficult one are the salivary, the peritoneal cytology, the fluid cytology, I mean, and the urine. But what has made it easy nowadays, that those big three has got guidelines now. So you have the international guidelines for the respiratory cytology, which was published in 2019. And this has made life easy because there is 1 + 2 + 3 = 4. The same things for the urine cytology with the Paris classification, and the same things for the Melang classification for the cytology of the salivary gland. So that means that for those who has the time to prepare, you need to read the 3 books, because each guidelines of those has published the book. But the book is not big. The book is small, and in the same way you have the Papinicolo Society publication for the pancreatic biliary cytology. And you have, of course, guidelines for the breast cytology, which doesn't come really in the FRCPath exam anymore, but just in case if it comes. But I mean, what it is that if you really wanted to build a solid base, then ideally you should read these guidelines as a book. But if you don't have the time and your exam is after 2 weeks and you don't know, then download the papers that the guidelines has been published. So for each of these guidelines, like the Paris classification of urine, you will find a paper of around 10 pages or something that explain and describe what this Paris classification is all about. And then you can use it. That will be the safest approach. And we expect, the college is expecting you to use the Paris and the Melang classification, because we do teach it to our trainee. So we are expecting you to answer your cytology down these lines. So in terms of preparation, if you have time, it will be about seeing cases as much as you can, up to reaching the magic number of 3,000. And in the same time, understanding and reading these guidelines, which is now has been published in individual books. These are international books, not American. A lot of British authors are there. Yes, any more questions, please?
Okay, great. Thank you, doctor. Thank you.
Any more?
Dr. Ali, like
Yes,
the data sets, are there any must-read tissue pathways?
No, you don't need to worry about the tissue pathway for this exam.
Okay.
Right? So just to focus on the data set. Yeah, any more question, please?
Dr. Ali,
Yes.
I have this pending question with you.
Yes, go ahead, please.
May I ask how you can calibrate the uniformity in FRCPath in different centers, a number of centers in UK, then overseas centers, different types of examiners, different personalities, different approaches. This is one. This is
for every exam. Thank you for the question. For every examiner, we have a marking sheet, so we don't mark you according to what we feel. We have a marking sheet so that will mark you against. So if you mentioned the point number 1, then you score 1. If you mentioned the 2 points then we have in our marking sheet, then you score 2. If you mention the point number 3, then you will score the 3 points. And then if you score these additional things, then you will score the 3.5 mark. So you don't get the full mark. So the exam, we mark you from 5 for every question in the short surgical or in the cytology. So you will score 1 out of 5, 2 out of 5, 3 out of 5, or 3.5 out of 5. But you don't, if you are the best person in the world, you will not score more than 3.5. Because we have a cap. Although the marking scheme is from 5, but you can't score 4 or 4.5 or 5 out of 5. And this means that your pass mark range is very narrow. And this is statistically has been calculated that way to see if you are a fine pathologist or not. Because if we left it to the 5 mark that people can score 4 or 5, then the pass mark or the range will be wide between the candidate, and we will not know the fine details between the people. So this is why majority of people who fail the FRCPath will fail the exam on 1 mark, right? But what happens in the center that you have 2 independent examiner that will mark every question. And if they give the same mark, then the question will not need to be reviewed by the head examiner. If the examiner give you 2 and the others give you 3, then there will be a third person who is the head examiner, who is a senior experienced examiner, who will look into your answer to see which one he will go for, the 2 or the 3 in your answer. And he will try hard to give you the 3, okay? So this is how it works. There is a marking sheet that's being given, and every examiner has been practiced against it before he sat in front of your paper to answer it. Every questions get marked by 2 independent examiners, and every examiner only will mark 1 or 2 random questions of yours. So he or she will not know who you are or what you have done in the question before. So because the question paper will be given as a number for the examiner, so they don't know whom you are, and they cannot correlate your previous answer for question number 1 for your question number 2. So there won't be any element of bias for the examiner to say, oh, he's done well in the first question, but he just was borderline here. No, that's not going to happen, because usually every examiner will be given a different questions to mark, and that questions will be random. So the same examiner doesn't give the same questions to mark it between different people. So and then we don't care if some of you written 20 pages about one answer and one written 1 page. If you've written the 1 page with the 3 points that we're looking for, then you will get the full mark, okay? And if you've written 20 pages and you did only hit 2 of the points that we mark you against, then you will get 2 marks. So it is not as complicated. The cases are the same in all the centers because the slide of the short surgical and the slides of the cytology and the slides of the frozen, the pictures of the macro will be exactly the same, that you will be distributed across all the centers in the UK and outside the United Kingdom. Okay, so
Yeah.
all the exams are exactly a copycat of each other. So there is no
Okay.
bias in this.
Okay. Regarding the remaining that, what is the level of difficulty in the neuropathology cases and inflammatory dermatopathology?
Neuropathology cases don't tend to come in the exam, and if they come in the exam, they come maybe as part of your soft tissue diagnosis, like a malignant peripheral nerve sheath tumor, which you might put it against synovial sarcoma, for example, and or it might come as a schwannoma in the GI tract or something, or a perneuryoma or something like that. Historically, in the past, we sometimes brought you an ectopic meningeal tissue in a nose, in the nose, or an accidental meningioma in a nose, olfactory neuroblastoma. Okay, so these are very common cases. But if you are talking about the other more complicated tumor of neurosurgery, like the choroid plexus tumor, like medulloblastomas, like the high-grade tumor that you get in the brain. What do you call them? I forgot what you call them now.
Like
you know,
astrocytomas,
astrocytomas, yes, so they will never come in the FRCPath. So if you really, so what I mean is, if the neuropathology is to come on FRCPath, it will be at the very basic level. We are talking as a baby level of schwannoma, malignant peripheral nerve sheath tumor, meningioma, but that's a common scenario in the nose that you always have to think of it. And of course, olfactory neuroblastoma as well in the sinonasal tumor. But that's about it. But apart from that, we don't give you any cases of neuropathology, because neuropathology is getting taught. We teach it in England as a separate pathway, 5 years training, that's completely different path from the general pathology. So usually if it comes, as I told you, it will be very straightforward case. So I wouldn't have a neuropathology book to read about it. No. So the short answer again is no. Or what you need to know, it is what's common of neuropathology that we see it in general pathology. If this will answer you. Yes. So
and inflammatory dermatopathology.
The inflammatory dermatopathology, you have a 6 pattern of inflammation, and the 6 pattern, I would say, the recurring case that keeps coming in the exam year in and year out are the cases which are the vesiculobullous diseases, right? So vesiculobullous diseases is a common cases that comes in the exam a lot. And the other one is to do with the necrobiotic cases. Now, if you are to start talking about spongiotic dermatitis and other interface dermatitis, and then sliceform dermatitis in differential of those and in differential of mycosis and drug relation and infection related, all of those don't tend to come. But what other things that can come is infectious diseases like leishmania, for example, that can come. So infectious, and of course other fungi that might come and harbor leprosy, all of those can come as well in the FRCPath exam. So infectious pathology can come as a skin, but if you really, really want to focus on few of the inflammatory dermatosis, then I will pay more attention to the necrobiotic inflammation. And how I will play the case like this, with all this differential around it, and because it is like an approach case, vesicular bullous disease, because that will also be an approach case to differentiate between the different types. And the third one that you will consider be the panniculitis, and with the differential that come across it. But that's about it. But again, it is a pattern approach. So providing that you give me the big heading, I see subepidermal bullous dermatosis, my differential diagnosis between bemphigoid, IgA, dermatitis herpetiformis, and drug or interface erythema multiforme bullous. Okay, then you know that differential and how you will play the immuno to differentiate between them, then that will be easy to do. But this is about it. So I wouldn't go and dig deep to try to learn the 220 entities of the inflammatory differential diagnosis. No, it is stay safe, stay by pattern. Okay, tell me what
great.
and what are the common differential here.
Regarding renal tumors, now most of the, if we see the epidemiology, most of the renal tumors, they are clear renal cell carcinomas, but there are a lot of variants. So as you mentioned, there is some nephrectomy case or nephrectomy specimen in the macros. So again, as you said, the pattern is common cases, not probably not the rare renal tumors.
Yes, in the macro you are not supposed to say, of course, but of course if you see the mahogany colored one that as we see it in the textbook, you should of course say, yes, I think it's well circumscribed. It has got this mahogany color. It probably can be oncocytoma, but obviously this my macroscopic impression. If you see a necrotic hemorrhagic tumor that you say, I think it's malignant, what is common, and what's common usually will be that you say, apart from between if it is an epithelial tumor or mesenchymal or a pelvic tumor, I would probably, if it is taking a lobe or a pole of the kidney, then you probably don't want to, if you can see clearly the pelvis is clear, then you say it's probably not a urothelial tumor, it's probably an epithelial tumor, because mesenchymal tumor at these sites are rare and they tend to be more exponentially peripheral, like the AML, but they don't tend to be as necrotic. Necrotic tumor will be most likely going to be what's common is common renal cell carcinoma. Yes. So in the exam, what tends to come is really the common ones. Mm-hmm. And you told me if you are to wanted to guess, then there will be a renal, the clear cell, the chromophobe, the papillary renal cell carcinoma. So you need to know those big three, and then the translocation one. So you want to focus on and of course then the AML as well. Yes.
Yes.
So but those and those what I will be focusing on. Sometimes gangliosarcoma can come as well as a benign case. People call it also clear cell because they see the macrophages as renal cell. But what I mean, I always tell people go back by the history of the FRCPath exam, because a lot of people get repeated, a lot of cases. And there are 150 or 160 cases. If you know them, you will probably pass the FRCPath exam. Mm-hmm. Okay. And historically, if you go back by the FRCPath, you will find that these are the common tumors that came in the exam year in and year out. If you wanted to go by the very rare tumor, these new entities that keep discovered and translocation with weird what I mean by the X11 translocation one, because macroscopically and histologically it is different, you see. But the other,
like now, fumarate fumarate hydratase deficient tumors and SDH tumors. Probably these are very, as you said, very rare tumors, and one shouldn't expect in the exam, right?
No, the very rare tumor that when you go to conferences and then, or you probably, for those who listened to USCAP last week, and they listen to all these new entities that keep coming, these are not the bread and butters of the FRCPath. That's beyond the FRCPath, because let's not forget the FRCPath is not your PhD exam in your country. No, this is an exam that's targeting level year 4 exam, year 4 registrar. And what we expect in the year 4, they know the difference between the renal cell, the chromophobe, the papillary carcinoma, and the X11 translocation one, but that's about it. You see? So that's about it. So you don't need to know all these 100 new entities that come for the FRCPath. You will be wasting a lot of effort and time.
Yeah, that's right. Thank you. And what about pediatric pathology? Like, okay, like as you said, we are seeing the rectal biopsies for ganglion cells, but there are some very specialized kinds of pediatric tumors.
I think there are very common trends nowadays in the exam of the FRCPath to try to avoid the pediatric tumor, because again, it's a completely different pathway for the college. We don't train on pediatric pathology at all in our practice here. It's again another 4 years of different pathway of training. However, in the past it used to come, but nowadays it doesn't. But if it is to come, you will be talking about the very, very common one, which we are talking about, Wilms tumor, or the soft tissue that happen at young age, that like rhabdo. If a rhabdomyosarcoma come in the exam, although it's a soft tissue case, but then we take it against the pediatric as well. So we say, if a pediatric team comes and ask us, if they say, did you put any pediatric case in the exam? Yes, we did put a case of rhabdomyosarcoma. Yes, that's a pediatric tumor. It happened in pediatric population, yes? Exactly. So therefore, we sometimes use the soft tissue case as Ewing sarcoma, or as a rhabdomyosarcoma as the pediatric case for the exam, right? So then, and if the worst come to worst, then we will be talking about the Wilms tumor or neuroblastoma, which I think everyone in the world knows about them.
Yes.
Yes. So, but,
yes,
but more than this, nothing more complicated than that. No.
What about the level of?
I will not go and have a pediatric book to read for the FRCPath. No. Yes, sorry. Any more questions from?
Can I just ask you that will you be doing that OSPE session where you discussed in the beginning of the session? Will you?
Yes, I think I will do this OSPE. Hopefully, yeah, I will try in the next 48 hours. I know the exam is coming soon, so hopefully in the next 48 hours we will do the OSPE session. Yes.
I really want to thank you for that. Thank you so much.
No problem at all. Thank you. Yes. Any questions from those who are sitting the exam in 2 weeks' time? Any questions at all? Anything in your mind?
Dr. Ali, what about the level of difficulty in sinonasal pathology?
Can we just give a chance for the other people?
Yes, sir. Yes.
Thank you.
Dr. Ali, please do a session on frozen as well, if you can, please.
Okay, I will do a session on frozen, no problem. That's
like how
fine.
Yeah, how to answer, because we have absolutely no idea being overseas, like how to answer.
Yes, I did
frozen.
already on few on my YouTube channel. So I think they
Okay.
were the most recent ones, you know, like
Okay.
the last maybe the 3 before last, I think, if I remember correctly, they were the one that I did on frozen section. But I can do more, no problem.
Okay, thank you so much.
Thank you. Yes, questions please from those who are about to sit the exams very soon.
Yeah, when you answer the long answered question and you drive at your diagnosis, when do you say that you would seek a specialist opinion, or do you say that at all, Dr. Ali?
Thank you for the question. Yes, you can mention this in the short surgical as well, but not in every case. What we tend to do is that if you have a soft tissue case, for example, and you are going to diagnose a sarcoma, as you know that nowadays majority of the sarcoma, even if you can diagnose it on H&E, it, ideally speaking, we should get the molecular specification for it, because it will guide the response to chemo. So therefore, you should say, I would like to refer this for a tertiary referral for additional, for the confirmation of the diagnosis and additional molecular work that will be performed, providing that you told me in the line before what molecular specification you might want it to do. Now, don't mention it in every question, because it will look silly, and but it's not going to harm you. But you mention it on the rare tumor. So, for example, if you have a glomus tumor and you are going to tell me I'm referring this, or a granular cell tumor, and you're referring this for a specialist because you hardly or you rarely see a granular cell tumor, then this will be wrong. The other things as well, which we don't want you to say is a renal or liver pathology, because I would expect you that, or the examiner is expecting that you already know this area. So don't tell me in the renal, and all what you can say in the renal, in the liver, and in the lymph node, that you would like to discuss it in the multidisciplinary meeting to plan for this particular reason, to notify with the type of cancer, to correlate with radiology, to see stage of this tumor, whatever you wanted to write. However, you don't want to ask for a specialist opinion, because that will really look silly. The reason why you wanted for a specialist referral, because you know that this case needs further specification based on molecular, and this is when we refer for a specialist center. So I would say I will use it more, mainly the word tertiary referral for the complex testicular tumor. Okay, so this is one area that I will be using for, and the sarcoma anywhere in the body. So sarcoma tumor anywhere in the body, I will refer for a tertiary center, as well as the complex testicular tumor. But other than that, I don't think this service should be centralized anywhere else in the world. I know that trauma now is centralized, but you can say, then I will follow the local guidelines in our trust, and if tertiary opinion is required, I would seek. So you can write it down here. Yes, thank you. Yes.
I was just asking if there are any MDTs for a non-tumor, like I've heard that they have MDTs for IBDs. So if there's a case for IBD, we should write that we will discuss it in the MDT meeting. So
yes,
any other non-benign, non-tumorous MDTs which happens in UK?
Yes, you should. Yes, these are good questions. I think one of the things is that you can always write, I will refer to the MDT, but the most civilized answer to say why you want to refer to the MDT. Yes, so the civilized answer to say that you would like to discuss option for treatment to stage this tumor, or you have some correlation you want to do with radiology or whatever you wanted to do. Okay, especially, for example, if you have a case that you have a metastatic tumor, so you would like to discuss this case, for example, in the tumor of unknown primary MDT, and this is because you would like to correlate with the PET scan results or imaging study to correlate with or to see what would be the possible primary, instead of doing a 50 immunohistochemistry to decide where your primary is going to be. Don't forget that the college don't like, or one of the things that you will be marked against, if you tell me that, or if you give me a list of 12 immunohistochemistry staining, we will consider that you don't know what you're talking about, because you should be very systematic and very economic as well, like direct to the point. You know what you're talking about. It's very easy for you to give me 5 epithelial markers, 5 soft tissue markers, 5 lymphoma markers, and let me to choose. It is not my job as an examiner to choose which one I'm going to use. You're giving me here a list of 15 markers. Is that what you're going to do? The minute that I give you the FRCPath, are you going to give me to do 15 marker on every case? I will fail you on the case. I will give you a borderline. Okay, so this is one thing. So the non-tumoral MDT, if you are going to fail like inflammatory bowel, because you will have to show the degree of uncertainty. But yes, it is a good practice to say, if you have a case of a Crohn's disease or ulcerative colitis, to tell me that I'm going to refer for the inflammatory bowel MDT. The other specialty MDT that we do in the United Kingdom are the inflammatory skin MDT. So the inflammatory skin, we have an MDT for it, as well as this. And we have also, if you have an interstitial lung disease case, then that's a third case which you will have to refer to a tertiary referral center, interstitial lung disease, because it is only centralized. And you will need, of course, to refer to the specialty MDT. So I think overall, you have, of course, the liver. So we have the hepatobiliary MDT for liver. We have the renal MDT for renal diseases, and the skin. We said inflammatory skin and the interstitial lung. These are the main areas, other non-tumoral MDT that we have in the United Kingdom. So these are the 4 or 5 areas that you will cover. Yes. Yes, any questions, please go ahead. Especially from those who are about to sit the exam, please go ahead, please.
If I write something, not intentionally, but maybe if I go wrong in maybe suggesting something like a treatment option or something, do I get negatively marked for that? For example, if something was supposed to be treated by chemotherapy and I wrote that surgery can be done on this, if something like that happens, do I get negatively marked for it?
No, you will not. If you, for example, say at the wrong translocation, for example, instead of writing X18 translocation, you've written X19. You will not be marked wrong. Like you will not have any deduction, negative marking, but you will not score the point for that, right? But if you wrote a wrong translocation, you will not. But if you write the wrong immunohistochemistry, like for example, I give you a nodular fasciitis case and you mixed up the USP6 with the STAT6, and you told me that you will use the STAT6 for confirmation of diagnosis, then you probably have demolished the entire immunohistochemistry mark. You will not get the immunohistochemistry mark, but you will get the diagnosis mark correct, so you will not be deducted the mark. So the wrong things that you write after you give the diagnosis will not deduct, but if it is wrong, it might take the credit from what else you wrote. Like if you tell me this is not melanoma because the S100 and melan A were negative, and the case was melanoma, then I will mark you down because you need to understand that metastatic melanoma can lose the immunohistochemistry. And if you don't know this piece of information, then you will commit this crime in the next day after the exam, and you will get a major case filed against you. So therefore, there are mistakes which are fatal because, and that reflects on the lack of knowledge, right? If you tell me this is not just because the CD117 is negative, then you don't need that. That mean that you don't know that there are CD117 negative GIF. Then your knowledge is not enough, and then that will lead you to the wrong diagnosis, and then you will get marked wrong. So what I mean is, don't write something that you are in doubt for. You don't write something on the paper unless if you are certain. But yes, if you do the minor fault, like a wrong translocation or the wrong immuno, that you've written it wrong, instead of writing HBME1, you write HMB1, this is okay. We will usually pass this. Yeah.
Thank you.
Thank you. Any additional questions before we finalize the session, because it has been so long for both of us, me and you guys? Yes. Any more?
Will this session be put on your YouTube channel?
Yes, we will. What I will do, I will send you the link with the session, so you can just open it with the link.
Okay.
Yes, because of course we keep the privacy maintained for those who ask the questions, and we don't want them to be identified, of course. Well, and that will be only for the people attended. They will be receiving the links. Yeah.
Okay, thank you.
Any more questions?
Dr. Ali, I asked that sinonasal tumors about yani.
Yeah, so well, sinonasal tumor, it's always going to be a simple one, because sinonasal tumor, when you get asked about it, it is either we will put a lymphoma case into an unusual place, and we tend to do that in the exam. Sometimes we give you a lymphoma in the GI tract, sometimes we give you lymphoma in salivary glands, sometimes we give you a lymphoma in the sinonasal area. But for the other sinonasal tumor, like the nut carcinoma, like the lymphoepithelial carcinoma, like the undifferentiated carcinoma, like those type of sinonasal tumor, no. The answer will be no. But the most common one that we tend to put, and you will, if you go back by the history of the exam, we tend to ask you, sometimes we put the neuroblastoma. The olfactory neuroblastoma tends to come a lot, or sometimes we put the soft tissue tumor, the rhabdomyosarcoma or the synovial sarcoma into the sinonasal tumor. So we can sometimes give you the sinonasal tumor at the soft tissue case, but if you wanted to know all these fine differences between the SCC, the undifferentiated carcinoma, the polydifferentiated sinonasal tumor, the nut carcinoma, all these new HCN1 carcinoma of sinonasal tract, lymphoepithelial one, no. The answer is no, don't. Because I told you again and again, whenever you revise, remember this is a beginning of year 4 level exam, and we are not expecting year 4 to understand these fine differences between the various sinonasal tumor. But yes, I expect the year 4 to tell me if this is an epithelial or non-epithelial tumor, and based on this you can build your differential, and that's it. But I wouldn't try to learn them by heart, no. So the answer is short answer again is no. The details in the books, not necessary and not needed.
Thank you. Thank you. Regarding lymphoma, lymphoma is a kingdom. Now, basically, it is a domain of hematopathology in certain countries. So, and most of them are, we see, are the large, diffuse large B-cell lymphomas and Burkitt, but sometimes every pathologist, he or she sees the T-cell lymphomas, angiocentric lymphomas, intravascular lymphomas. So what I understood that in the regarding lymphomas, one should also expect the common lymphomas, right, sir?
That's absolutely correct. I think the most weird one that tends to pop in the exam is the T-cell lymphomas with some of the variants of it. And this is the one that if you really wanted to read deep, I think you need to know the major types of the T-cell lymphomas, like the angioimmunoblastic and the
peripheral T-cell lymphoma and
lymphoma. Yes, but and anaplastic, of course. But apart from that, that's as difficult as it gets. But then what's common is common. What tends to come in the exam, if you really in the exam and you play the clever rule and you write for me, this is a low grade this is a low grade B-cell lymphoma with diffuse pattern, or this is a low grade B-cell lymphoma with nodular pattern, believe me, this sentence alone will make you pass the case. This sentence alone, because you categorize, this is non-Hodgkin, B-cell, low-grade B-cell lymphoma with diffuse pattern. You see, this sentence has got it all, okay? If you can read this sentence and write it, and you can classify, this is as far as you can go with the lymphoma, then this answer will be the safest, and this will make you pass the exam. Of course, from B-cell, if you are going to differentiate on the short surgical, it has to be obvious. But I mean, it has to be either a band, it's a straightforward B-cell lymphoma, like a follicular lymphoma without immuno, or it will be a Hodgkin, which you can see hundreds of Hodgkin cells, and you say, I'm favoring this to be Hodgkin based on the mixed cellularity and the Hodgkin cells, but I will still confirm this with the immuno. But if it is coming in the long surgical, you can take it a step further to say Hodgkin or non-Hodgkin, B-cell or T-cell, and then you classify as low grade and high grade and give me the differential. But that's as far as you want it to go. Again, we are not expecting you to know the fine differences between the variants of mantle and the variants of marginal and how you mix between them and all these sort of things. And this is where people go wrong. People forget the exam is approach, and they tend to jump for the diagnosis because they play the clever game. Oh, I'm so clever, I'm going to call it marginal lymphoma. And then they go hit badly that it was the cyclin D1 negative mantle lymphoma, and therefore they got it wrong. They got it wrong because they didn't show the examiner the approach. They didn't leave for themselves a space to be able to score, okay? And this is where they go wrong, and this is you see, my opinion is, and this what I will close the session with, if you don't fail the exam because the exam is difficult, you fail the exam because you didn't show your approach to the examiner. If you show me the approach every time you answer the question, and you start your answer by giving me the heading by which category this tumor belongs to, and you favor the one out of your differential diagnosis, if you do that, even if you favor the wrong one, I'm telling you, you will pass the exam, okay? Because you've shown me the approach, you've shown me that you are going to pass, you will eventually get the right answer, either with your immuno or with your additional test that you would do. But if you don't show me that, then you will fail. And if you don't show the pattern for the examiner, I'm not going to come and visit you in your house and tell me, what did you mean by this? Did you have this approach in your brain? And the one final thing for you guys, and we will definitely close this session now by this, is remember that this is an exam. You might get asked about lymphoma once in your lifetime. Tell me what you know about lymphoma when you answer this question. Show up the examiner what you know, okay? Don't play the clever rule about the good guy who knows the diagnosis in the shortest path. That's not what the FRCPath is about. The FRCPath is about you showing me the knowledge behind you being able to reach that diagnosis. If you remember that, you will pass the exam safely. Show me the approach, I will let you pass. You don't show me the approach and you play the clever game, you will fail. And by this, I would like to thank you all for participating in this session. I hope that it was useful for all of you, and please keep sending me your questions. And you have the iHistopathology, the admin at iHistopathology.com, and this is the email. And just send us your questions, and I will be happy to answer them. I'm sorry it was a long session, but I hope you find it useful. And thank you very much for listening and tuning in today. And all the best, and best wishes and good luck for your exam.